This is DC EKG, exploring the intersection of politics and healthcare by diagnosing Washington and prescribing solutions. We take a deep dive into the legislation, regulation, and innovation impacting policymakers, providers, and patients. Now, America's health policy expert, Joe Grogan.
Welcome back to DC EKG. I'm your host, Joe Grogan, joined today by Ryan Long, otherwise known as the smartest man in healthcare, formerly of Kevin McCarthy's staff in the Speaker's office, Energy and Commerce for many years. Now he's at the University of Southern California, the finest institution for higher learning in the United States, and Paragon Health Institute, another fine organization. Today, we were going to do a year in review episode, but there already are a number of fights going on in healthcare. So I want to talk about the immediate fights right now as the principal conversation. Then we can talk a little bit about 2025. But I think, Long, I would like to have you back to talk about the first 12 months of the Trump administration. And, you know, that anniversary is coming up in a couple weeks. So that might be a good marker for when they came into office. So let's talk about something that's been in the news recently, which is Maduro getting taken over by Delta Force. Now we can talk about that offline, but the California wealth tax issue has been percolating recently, and this is a tax that the California legislature and their Democratic governor, Gavin Newsom, who's planning on running for president, they're saying they want to put in a temporary tax paid for on the wealthy, of course, because they don't like the wealthy. At least they say they don't. And then it's payable over 5 years, and it's going to go just to pay for healthcare. This sounds great. I care about people. I know you care about people. You must want rich people to pay more for working Californians to get real high quality healthcare, right?
Well, it's interesting that the debate's happening at the exact same time that we're uncovering all of this fraud in Minnesota, healthcare programs, Ohio, Maine. A lot of people are focused on the waste and abuse in healthcare programs in California, but they have long-term structural deficits. 4 years ago, I think they had like an $80 billion surplus in California, and now they're running kind of the equivalent deficit. So the thought is let's do a one-time tax with people with assets over $1 billion. Now, they've already seen people leave. I think that there were people that have moved to Florida, moved to Texas to try to avoid that tax. And so they're going to depress their tax base that way. The other thing, and other people far more knowledgeable than me on sort of the California tax policies, the way that it's structured is you don't even have to have $1 billion. If you start your own company and it's on paper, you may actually have to sell your company in order to pay the revenue tax. But putting that aside, and let's just say, how does this affect California's budgets now and in the future? They claim that it's a one-time tax, and it's 5% tax on anything over $1 billion payable over 5 years, thought to raise about $100 billion in revenue. Well, what happens after those 5 years are up? They haven't addressed any of the structural issues with their budget. They haven't addressed the fraud and abuse in their healthcare programs. We think it's a one-time tax. I mean, I think that's just, it's not realistic, one, or two, it's intentionally deceiving. I think one of the things it reminds me of, Joe, was the ACA. They included this tax that was going to be on the wealthy, a Medicare tax. In fact, I think they called it the unearned income Medicare contribution in the Affordable Care Act. And what that did was it said, any individual that had an income at $200,000 or family that had an income of $250,000, they would pay an additional 3.8% tax on any unearned income each year. Now, that affected about 1% of the population when it went into effect in 2013. It's raised about $455 billion since its inception, but they never indexed the income threshold. And so instead of 1 to 2% of the population, now about 5% of the population is paying that, because it's still $200,000 for an individual or $250,000 for a family. And it's expected in the next 10 years, it'll get up to about 12%. So of that $455 billion, Joe, how much do you think went to the Medicare trust fund?
Well, if Nancy Pelosi said that it was a tax for the Medicare trust fund, I would say it would have to be 100% of all that tax money must have gone into the trust fund. That's what she said where it was going to go, right?
Yeah. So the answer would be zero. None of that money.
Zero?
Yeah.
How could that possibly be?
Great question, because we were told it was an unearned income Medicare tax. So with $455 billion, if that money would have been in the trust fund, instead of the trust fund expiring in 2033, as it's expected now, it would have been 2038 or 2039. Moving forward over the next 10 years, it potentially would push the insolvency date out to 2044 later.
So where'd the money go if it was supposed to go into the trust fund? Where was it diverted to?
It was diverted into the general treasury so they could pay for whatever other pet projects they wanted to pay for. But it did not go to the Medicare program.
That reminds me of the individual mandate penalty, which we were promised was not a tax, absolutely wasn't a tax for not buying health insurance. And then it got to the Supreme Court and it was the whole law was held up because it was a tax.
Magically.
And not an affirmative obligation to buy a commercial product, right?
So this is a Medicare contribution that's not a Medicare contribution.
Well, that doesn't sound just to me, the whole thing. So let's go back to this California situation, because I think it's illustrative. California has not been invaded by a foreign power. They have not had a massive earthquake that blew up their budget, although they did have the terrible Palisades fire. And I was there the beginning of December, drove up the coast or into Malibu and saw the destruction, which it continues to be really horrifying. I mean, there's still burned out cars on the hillside, houses in disrepair. It's really shocking to see what's going on. Houses running on generators on the coast. You know, there's no linked up power from a municipality that I could see. You know, people are running their houses on generators. And I didn't even go inland. I was just on the coast, which is, you know, obviously an incredibly...
How many homes did you see that had been rebuilt?
I did not see any rebuilt homes. I didn't see any rebuilt homes. I didn't see... I saw a lot of for sale signs for houses that had survived. But I think the owners were just like, I've had it. I'm done. Trailers parked on beautiful pieces of property. And I just didn't see it. I mean, it was really shocking. As much as you can see it on the news, to go there in person and see it is unbelievable. But as an aside, all that is to say, why would you need a one-time tax? Why is this not an admission that the Democrats have a supermajority in the California legislature have mismanaged that state horribly and have built in a structural budget problem by mismanaging these programs? And why wouldn't that be the entry point to any type of tax? It seems to me that if they were to say, okay, we screwed up, we made a horrific mistake on this element of public policy, we were spending too much here, and here, we need permitting reform, and they had a series of things they were going to do to fundamentally restructure their budget. And to get over the hump, they said, we need a one-time tax of some sort. That would still be offensive to me because I wouldn't necessarily trust that they would follow through. But they're not even doing that, right?
No,
they're not saying, they're not admitting that they made a mistake.
Or here's our plan on how we're going to have a long-term sustainable budget in California. They're not doing any of it.
Which is crazy, right? Because how could a one-time tax solve a long-term sustainable budget problem?
Well, and that's why the idea that if they start to rely on this, that it's a one-time deal, I think it's a fantasy. And I think most people will, and most job creators will understand that. And you'll see a continued exodus, which will be counterproductive to the state of California because those people already contribute the vast majority to the income tax of the state of California.
Yeah, I mean, it's brutal to see what, as a previous resident, proud former driver's license owner from the state of California, it's crazy to see the state just drive itself into oblivion.
Well, and, you know, if you chase out the high earners that are responsible for the vast majority of income tax, now you're going to even have a higher tax burden on the middle income families in California.
Of course. But it's interesting too. I mean, this is why President Trump recently did a meeting with congressional leaders and it was, behind closed door. But supposedly Trump said Republicans haven't been on offense in healthcare. We've got to get on offense in healthcare. We got to start winning on healthcare. It really is true, taking it out of the political lens, it's important for conservatives to fight on healthcare because the Democrats in the California legislature who have screwed this up so badly, they're not saying, oh, we need a one-time tax because we screwed up the budget, right? They're not saying we need a one-time tax because we need to increase pay for state workers and continue to overpay for public infrastructure projects. They're focusing in on healthcare because who doesn't want healthcare? Everybody wants healthcare. So that's, they think, is the best way to sell this massive tax increase. They target the rich and they say it's for healthcare. Meanwhile, it's to cover up their own mismanagement of the fisc.
Oh, 100%. Like you said, if they were serious, they would say, here is our plan. Here is why a one-time thing is needed. Now, there would be severe, I think, economic consequences even if they did it one time. I'm just talking about how laughable it is to try to suggest that they're going to do this one time and not be providing a plan on how they're going to have long-term sustainability for their budget.
Right. I mean, these things are always billed as one time. The income tax itself was billed as a one-time tax that would go in. The throughway taxes or the highway tolls are always billed. Oh, we're going to put tolls in until the bridge is paid for, until the highway is paid for.
And they're going to come down.
Yep. And it never happens. These things never go away. Okay. So that's a good bridge here to talk about where we are on the Affordable Care Act enhanced subsidies fight. Now this, to flash backwards or recap, we had a shutdown in the fall where the Democrats in the House of Representatives said, we're not voting for a continuing resolution. We demand that the temporary enhanced subsidies that we put in place during the COVID emergency, and we put in that they would expire after a few years, those need to be extended. So not one Republican had voted for that at the time. Not one Republican had voted for the Affordable Care Act. Democrats put this in the law, and then they come in and they say the Republicans have to extend them. After a whole bunch of theater, Sturm and Drang, and back and forth, a temporary continuing resolution was passed, which expires when?
The end of January for most departments.
Okay, so end of January. So we don't have much time to sort this out. Well, I don't know. I'm interested in your take on it. I thought this was the first time I thought that Republicans did a halfway decent job pushing back on the Democrats' narrative on healthcare. They did cut through with the mainstream media in certain circumstances. I think Democrats are still happy they did the shutdown. I think they needed to do that for their base to show that they, quote unquote, had some fight in them. But I thought on substance, the Republicans came to this discussion about fraud and mismanagement in the Affordable Care Act pretty strongly. And the same thing with some of the discussion around Medicaid. Then subsequently, we have the blow up in Minnesota where Tim Walz, who was just yesterday the Democratic nominee to be the vice president of the United States, is now had to come out and say he's not running again for re-election because so much paint had been taken off his sides because of this exposure of the massive fraud in Minnesota. So where are we? Where does Ryan Long see where this fight is on the enhanced subsidies right now? We probably could spend a couple hours just talking about the last 3 months in the healthcare fight, but what's going to happen as we get towards the end of the month?
So you mentioned it was the Democrats that created these in March of 21, which if you look at March of 21, there's a good demarcation line in terms of how the economy was doing and what it was doing before March of 21 and then after March of 21. And that's really when sort of inflation took off, going from 2% to 9%. But they created in 21, they extended them in 2022, and these were always couched as credits to address the COVID pandemic. So in 2022, they scheduled them when the pandemic, public health emergency was still ongoing. They extended them until 2025. There were a whole host of other things, tax items that they did in 2022 that they did for 10 years or they made permanent. But for these, they scheduled them to expire in 2025. Now, what they were doing in September or October was this kind of sleight of hand. They were saying, we want to extend the ACA credits. And there were polls that were done by various groups that said, hey, Americans, do you support providing assistance to people to purchase health insurance? We do so with tax credits. They expire at the end of 2025. So they were providing the impression that all of the ACA tax credits expired, not the COVID credits, because they wanted to scare people into thinking that all of them expired. So what happened? The normal tax credits didn't. They're permanent. They will continue to go on. A family at 4 that, they make, let's say $80,000, they'll pay the same amount in premiums that they were paying in 2019, 2020. Premiums have gone up substantially because of a lot of the issues fundamental to the ACA, but the increase in premiums are being borne by the federal government. So the COVID credits go away. We go back to the ACA credits prior to 2021. And so we had the shutdown. Now, what did those COVID credits do? One, there was a fundamental problem in the structure of the credits in the ACA, in the fact that a lot of tax credits based off of income, if they phase down once you reach a certain threshold, they just don't drop off a cliff. But the way the ACA credits worked is if you're at 400% of poverty, you either get the credit, but if you're at 401% of poverty, you get nothing. Now, instead of responsibly sort of phasing that down, the 2021 tax credits that the Democrats want to extend, they just didn't have an income cap at all. So, there's people in places in Arizona make $500,000 were getting tax credits to buy insurance.
Can you back up for a second? Wait, I want to hit on this point. So they not only did they increase the amount of the tax credits, or they pulled the income limit.
They got rid of the income cap and they increased the amounts.
So they did both. Now, the income cap has not gotten a lot of attention, I would say, correct?
Well, I think it has, in the fact that if you look at many of the examples that are brought up, and particularly when you hear people bring up examples of the dollar amounts that people will pay, not a percentage increase, dollar amounts, it's people above 400%. Like I said, they should have structured the premiums a lot of different ways. I mean, one, it shouldn't be a cap on income. All other healthcare programs that have premiums assistance, it's a percentage of the premium, because you want the premium payer to be somewhat sensitive to the increase in premiums, because that way there's an incentive to keep spending low. When you do it as a percentage of income, the amount the individual has to pay is capped. So if premiums increase dramatically, they can continue to increase. It's just paid for by the federal government. So that was one mistake. But the other mistake, like I said, is most tax credits that have a income cap, they phase out the eligibility. They don't just cut it off. And the ACA just cut it off. And so if you're at $399 or 400% of poverty, you get a tax credit. You make $5 more, you don't. So the Democrats want to bring that group up. And I think, frankly, that is a group that we should, people should think about how to address. And one of the things that the Republicans did in December, they passed a bill to provide those people more health insurance options so they can go outside the exchange and get something that costs a lot less. Unfortunately, there's not going to be Senate Democrat support to pass that. But that's one thing. The other thing that the credits did, they made what was known as $0 plans much more prevalent. And that is for a large group of people, they don't have to pay a single dollar towards their premium. And so where you've seen all of the growth, or the vast majority of growth in enrollment since these COVID credits were established, it's those people that don't have to pay anything. And that's where we believe at Paragon that there's a lot of fraud. There are a lot of people that don't know that they're signed up. There have been numerous stories in Bloomberg and other places about how unscrupulous brokers have used these $0 premiums to just get, hand over fist commission checks. We estimate around 6 million people, up to $27 billion a year. It's costing us in phantom enrollees, because people don't have to pay anything. You don't even have to pay $5 for your coverage. And so we've seen a lot of fraud there. And sort of buttressing that argument, In a normal healthcare market, you'd have about 15 to 20% of people that don't have any claims in a particular year. That's normal. In that fully subsidized, they don't have to pay anything market, that number is 40% of people didn't use a single service. They didn't fill a prescription. They didn't go to a doctor. They may not even know that they're signed up, but the check goes to the insurance company from the federal government each month. It's so really ensuring that people actually have to pay something. And we're not talking about a lot. Under the original ACA, as the Democrats wrote it, those people would have to pay up to 2% of their income. That amounts to $25 a month.
Right.
For almost fully subsidized health insurance. The taxpayers are paying 98% of the premium. And even with the expiration of the tax credits, because plans of states have used this thing called a technique called silver loading, a lot of people are going to be moving from silver level $0 plans to $0 plans in the bronze level. And in some cases, gold plans are cheaper than, or you can get $0 gold plans because of the way they've structured how the credit is calculated. So there's a lot of distortions in the market, but if you want to address fraud, and especially after what we've seen in Minnesota, what's coming out California and other places, we know there's massive fraud in healthcare programs. You can't just have a blank check, and you have to have some regulators in there to stop people preying on federal programs, particularly when you're talking about now a program that's over $30 billion a year. We know people are going to come after that money. And I think it's only the responsible thing to do to have safeguards in place. And the best safeguard you could have is ensuring that those people that are signed up actually want to be signed up, they're enrolled, and you can do that through a minimum payment each month.
I'm surprised at how indifferent the Democratic establishment seems to be to the fraud. To me, it's sort of bizarre to watch. I know they hate everything that Trump does or he's attached to, and we're in this sort of tribal period, but why nobody's popping up and saying this is awful? I mean, the Attorney General for Minnesota, Attorney General Ellison, is out there saying, oh, there's nothing to see here. There's no fraud. There's no. Meanwhile, the governor just said he's not running for re-election, and the numbers continue to get horrible as far as the amount of money that's been diverted. It's just bizarre to me to see the Democratic Party defend rampant fraud like this. It's discouraging because if you can't expose and cut fraud, what can you fight? These arguments are really tough to how should you structure healthcare? How should you take care of the poor, the middle class? How do you regulate various products? But when there's total indifference and even defense of fraud, I'm probably more discouraged than ever.
I think a lot of rank and file Democrats, they're probably appalled by what's happening in Minnesota. I think for some, healthcare programs are so prone to fraud, undermines their desire to completely expand them further and further. People want to go to Medicare for all, right? Where, DC bureaucrats get to decide, what you get, when you can have it, what you can't have, what you can't. You do that, then, you're going to get back into the sort of the Politburo days, right? Where the well-connected get what they want, and the well-connected are going to siphon off their piece, and people that suffer are the people that need the services. And so I think for some people, they can't admit the faults of the government because their answers are the government.
Right.
So it undermines their answers. I mean, just look at what they're potentially doing in New York City on housing, right? People don't trust the government, but they want to say, hey, we want to take over all housing. How is that going to work out, right?
I know New York's going to be an interesting experiment to watch unfold, and could be a great series of conversations in the future across a whole range of issues.
But 1 year ago, the talking points coming from a lot of left-leaning healthcare think tanks was there's no fraud in Medicaid. What are Republicans thinking about? There's no fraud in Medicaid. And, the more and more there was the layers of the onion were peeled back. I mean, the more and more that they were exposing, I think they did a good job to address. I mean, like one of the things that they had in the Working Families Tax Cut Act is to say, you know what, Medicaid shouldn't pay for the same person twice in two different states. That's common sense stuff. But like that reconciliation bill sort of just scratched the surface of the fraud that we have in programs. When you have the the U.S. attorney in Minnesota, I think he said in 14 different programs over the last 7 years, they spent $18 billion, half of which was probably fraudulent. Now, if you have a 50% fraud rate, like what does that do to the confidence that people have in those programs?
Right. Yeah. I mean, there's a whole class of commercial activity that's built upon fraud. So that's a direct threat to them.
But Joe, going back to the tax credit, we know there's massive fraud with the $0 plan.
Right.
That's something that Paragon has mentioned, that members on the Hill have mentioned, that other groups have mentioned. And the answer is we don't care. We're going to do it for 3 years. No reforms whatsoever.
Well, but the offer that the White House put forward had some reforms, right?
Well, I'm talking about where the Democrats are. I don't know that the Democrats actually care really about getting this done. I think that there are rank and file members that do. But in terms of their leadership, why would you be insisting? I mean, they shut down the government and they said, we're not going to vote for anything that's less than permanent, even though they were the ones that voted to end them in 2025.
So all political theater is what you're saying.
Yeah. I mean, I think that there's the timing of when the shutdown ended is coincidental. It ended right after the November election,
which the Democrats did well on across the country.
Yeah.
Right.
But one of the things, if you're in the minority in Congress and you have a priority you want to get done, you don't wait to the end and then say, do it my way, no way, or we'll shut down the government. You need to go to, you're going to the majority and you're saying, hey, listen, we know this was a Democrat-only provision. We know you have problems with it. Is there any way to get to yes? They didn't do that. They didn't do that the whole time during the shutdown. And then when it says, okay, we're going to come up with a vote, they do a length of time that they know that even some members that have said they're interested in extending in a reformed way think that that's too long of an extension. So they go for an extension that people thought was too long with no reforms, even though there's been more than documented, including from the Congressional Budget Office, of millions of fraudulent enrollment that's lead to tens of billions of dollars that shouldn't be going out the door.
So from a practical perspective, how do you see this plays out politically? So this is not going to get extended, right? And the government's probably not going to shut down. So these things expire at the end of January. Where do you think people are in June, July when they look at their ACA monthly bill? And are they blaming Republicans for what they're paying? Are they blaming Democrats? Are they pissed off? Are they saying this isn't as much of an increase as I was led to believe, because the Democrats are saying wanted me to believe that all the subsidies were going away? And I think some of the mainstream media reported like massive increases reflecting all the subsidies going away and not the enhanced subsidies. But there are arguments to be made that there are going to be increased costs of some significance for some people. What does your gut tell you about where people are 6 months from now as far as how they view these enhanced premium tax credits from the COVID emergency that have gone away?
One thing to consider is the other thing that they've tried to provide the impression is that the credits apply to everyone that has commercial health insurance. And these really only apply, well, not really. These only apply to people that get insurance in the exchange. Now, one of the problems is these exchanges are just inherently flawed in how they're structured. They are designed to have ever increasing premiums. They have a regulation in the law that it sounds great. And that's why a lot of, we talked about the California wealth tax and it sounds great. And you're like, well, okay, let me do a minute's worth of sort of thinking about it. And you see all of the flaws and the unintended and potentially intended consequences that come with that. But the medical loss ratio, it sounds great. We want to make sure that insurers pay a certain percentage of their premiums towards claims. What you have is, if I reduce my premiums, I make less profit per member per month. I make more profit per member per month if I increase my premiums.
Yeah.
If I keep people healthier and not using services, I lose money.
I know. It's insane.
If I increase reimbursements to large hospital systems and increase my premiums, as a result, I make more money. And so we have a very convoluted insurance regulatory system within the ACA. I think you're going to have some people, to your point, that were under the impression, and I saw chat groups from insurance brokers on the first day of open enrollment, and some of them were even surprised that people were still getting their ACA subsidies. And the people they worked with were surprised because they were told that they were all expired, not that they would just revert back to the amount that they were paying in 2020. So I think you'll have some there, but there is a call to do something about healthcare costs. And I think we got to do, or policymakers need to think about in a couple of different ways. I mean, one is how do we address some of the convoluted nature of the ACA insurance market, right? You got to address the perverse incentives within the medical loss ratio.
Well, can I ask you a question? Because you know the Hill better than anybody. Why not just put that as a standalone bill? Repeal the medical loss ratio provision from the ACA. Put that up, straight line vote. Why should that not pass with 80% of members voting in favor from that?
Because I think what you would have is, it was sold as, we're going to make sure insurance companies aren't hoarding your premium dollars for profits. That's how it's sold, right?
But so much of the ACA was sold with promises that didn't play out. So is there not a recognition that the MLR is a stupid idea? And even though it was well-intentioned, it has failed to control costs. And a matter of fact, profits have gone through the roof. And the only way for profits to go up is through increased premiums. I mean, I don't mean to be dense. I'm really asking a serious question. Is this just straight up politics?
But I think so. Because if you look at the debate over the last 6 months, you were working for President Trump in the first administration. Basically, there's a reflexive position that we can't do anything. We, as Congress, from a Democrat position, to change the ACA, because then we're fundamentally admitting that it didn't work. Even though during this debate, we've had senators go on the floor and said, it didn't work because the ACA actually didn't bend the cost curve down. It actually bent it up. The MLR is one of the reasons it got bent up.
Yeah, but okay, so let me ask you this. The other side of that coin is that Republicans did not want to vote for any amendment to improve the ACA because they had locked themselves into this repeal and replace argument. Is that over? Is that side of the coin? I mean, can Republicans get to a point where they could vote for reforms to improve the ACA? And then the only thing you need is enough Democrats to say, yes, we want to improve the ACA. Are we still locked in this argument of a negative versus a positive and never the two shall meet?
I mean, I don't know, but we do have to recognize that, we say the ACA, but what we're talking about is the individual exchange market, right? And the individual market existed before the ACA. It has been much more tightly regulated, and we've taken away all other options for people to buy outside it, virtually. I mean, there's still some. We say the ACA, we mean the individual market. The Republicans, and I don't know, is how can we do things to just repair what's happened? I think that there is a willingness. If you look at the House reconciliation bill, they appropriated what was known as cost sharing reduction subsidies. There's an error in how there are many errors in how the Democrats wrote the ACA back in 2009 and 2010, but one of the errors was they didn't provide an actual appropriation for cost sharing reduction subsidies. That massively increased the premiums for the benchmark silver plan and thus massively increased the spending on premium tax credits. That case was litigated and it was found out that no, there wasn't a valid appropriation. And so the Trump administration complied with the court order. States responded by doing this silver loading technique. Well, the Republicans in the reconciliation bill, they would have appropriated cost sharing reduction subsidies permanently. It would have reduced spending on the tax credits and reduced overall federal spending by $30 billion over 10 years and reduced premiums for silver level benchmark plans by about 12%. And that's a massive reduction, particularly for those people above 400%. And Senate Democrats said, well, that doesn't comply with the Senate reconciliation rules, which I don't know why on earth it didn't comply. But they got it kicked out. And so something as simple as that, something that you had people like Chuck Schumer and people like then the ranking member of the Senate Health Committee, Patty Murray, supporting cost sharing reduction subsidies appropriation, saying if you don't do it, you're going to ruin the ACA back in 2017, 2018. Now, all of a sudden, they're opposed to it. So they're opposed to doing anything. They're opposed to working with Republicans on anything that might actually lower healthcare costs in the exchanges or for families outside the exchange.
Right.
The other thing is you got to fix that. You also have to provide people more options outside the exchange to enhance comfort.
Oh, no question about that. I want to see the association health plans and the short-term limited duration plans and get expanded and enshrined in law. That'd be great. And there should be catastrophic plans, and there should be why there's this war on options. I find infuriating, but we've got to talk about your subject, and that was pretty depressing. So thank you, Lon. I appreciate us kicking off the new year with that.
Well, no, the one thing that's not depressing, Joe, is there's been a conversation that goes beyond the COVID credits, and actually people are getting attuned to, wait, why are healthcare costs going up so much? What's happening? Why is there so much consolidation amongst providers? How can we inject more competition and provide more options to people? So I do think the fact that conversation is now happening when basically it's been on the back burner forever is probably a good thing. And maybe there'll be some results that come out of that legislatively, but certainly administrative.
To your point, the insurers were fighting for these premium tax credits to continue. Trump has been hitting them with both barrels and hitting the economics of this as only he can in dominating the megaphone. And he's been asking for meetings with the insurance companies. One has to wonder if they are at a critical decision point. Will they make the same mistake the drug companies made 10 years ago in refusing to admit there was a structural problem with Part D and focusing on some of the structural reimbursement problems instead of just vilifying the PBMs and turning Trump away in the first term, which led directly to the passage of the Inflation Reduction Act, and now the Globe and Guard models, which are an additional layer of negotiation, and rather than work to improve the structural inefficiencies and distortions in the reimbursement legislation and regulations for drug companies. The insurance companies may be on the verge of making the same mistake, because if they think that they can crawl into bed with the Democrats on all these enhanced subsidies, and this is going to go on forever, and they're not going to have a boomerang come around and slice their Achilles tendon, I think they're fundamentally wrong about that. They are on a clock, and they are going to end up having a cut on their reimbursement somehow, and there are going to have to be changes to the ACA. It can either be with market forces or it can be with rate setting, and they've got to figure out what they want. It may take a year, may take 10 years, but it's going to happen.
I think that there are market-based, competition-based ways that you can help reduce premiums. You can take away the inflationary aspects of how the credits are structured, and you can provide people more choice and competition. If not, you may end up with the equivalent of the rate stabilization type system that we were recently talking about in New York,
right?
Which we know doesn't work, in which we know raises cost and limits supply.
Yeah. Okay, we know. All right, so we got to pivot. We could talk about this. We can have this discussion again shortly. But 340B, your favorite subject and mine. You recently wrote an outstanding paper about 340B, and you think it's not running all that well. So what's your latest thinking over the break as you were singing Old Lang Syne? What were you thinking about with 340B?
Well, thanks, Joe. So, I think it was end of September, beginning of October, colleagues of mine and I put out a white paper on the 340B program. And basically what we did is let's just be honest about the program. The program fundamentally is drug manufacturers are subsidizing the operating costs of tax-exempt hospitals. That's fundamentally programming to the tune of over $60 billion a year. But what we go into in the paper is the structure of the program is built on this fundamental foundation of they get a 340B discount that's way down here, and then they get reimbursed from whoever it is, whether it's Medicare, Medicaid, commercial insurance, at their regular reimbursement rate. Well, since commercial insurance reimburses so much higher than Medicare, the more commercially insured patients you have, the more money the entity is going to get from the program. And the more uninsured patients you have, and the more patients you have with Medicaid, the less money you're going to get from the program. Well, what's a good proxy is the fact that hospitals that have high commercial reimbursement rates and low uninsured rates tend to be more financially viable and wealthy. So why do we have a system where the vast majority of the benefit goes to the wealthier entities, and those that need the benefit the most get the least from the program? And so we kind of lay that out, and we actually have a very good sort of pictorial in there that shows a hospital with a very large commercial mix and very low Medicaid, very low uninsured, versus a hospital with a low commercial mix and high uninsured and high Medicaid. For the exact same drug dispensed 1,000 times, the hospital with high commercial rates makes over $12 million. And the hospital with low commercial rates makes $3 million, 3.4, I think it was.
So wait, I'm going to stop you right there. This is an argument that you guys seized upon. Has anyone made this argument before?
People have definitely made the argument that the 340B program is drug arbitrage.
Yeah, that's true. But this distinction about what you're talking about with the rural hospitals are getting screwed and the big hospitals, because frequently people who defend the 340B program, their poster child is a bedraggled, desperate rural hospital serving the Clampetts, or an inner city hospital working 2 blocks down from the projects. But you're hitting on something. I think you and your colleagues at Paragon hit on something here that a lot of people weren't really arguing.
Well, you're right. That's who they put as the poster child, but the vast majority of the money goes to richer, wealthier entities. And in fact, even for poor hospitals, they have an incentive due to the structure of the program not to increase services in their area that they serve, but to go out into richer areas where they have high levels of commercial insurance and buy physician practices there because they can take advantage of that spread. And so the defense of the program, it is true, there are hospitals that do rely on the revenue they get from the 340B program. I think any reform should make sure that we change the program in a way that the assistance is more directly targeted to those hospitals in need and not to wealthier entities just because they have a very high commercial payer percentage. And that's what we have now. And I think if we went to, the other fundamental problems with this setup is we provide an incentive for 340B entities to use higher priced drugs so they can make more money off of it, to use more volume of drugs, to use less biosimilars. So that increases Medicare spending. It increases the cost sharing that Medicare beneficiaries have in the program. It increases commercial sector premiums. But then it also, because like I said, they can go out and buy a physician practice that's independent, that physician practice is buying drugs at the normal commercial level. If the hospital buys them, then they can now start buying the drugs at the 340B level and pocket that spread. And so we've seen over the last 15 years since the program really expanded, more and more independent physicians becoming hospital employees. And it's primarily because of 340B, and it's because of the non-site neutral payment that we have in our healthcare programs, where you get paid a lot more for the exact same service done just because of where your banner is put up, rather than the service that they provided. And so we're increasing costs to federal programs, to commercial insurance. We're incentivizing consolidation, and we have a program where assistance doesn't go to those hospitals based off of their need. It goes based off of how wealthy they are or their payer mix. All of the kind of reform proposals that have been put out there do some good things to address some of the abuses in that program. But they don't actually fix the fundamental problems that I just laid out in terms of consolidation, increased federal program costs, increased commercial premiums, or the direction of assistance.
You want to reform 340B by turning it into more of a grant program for poor hospitals and eliminate the drug arbitrage, the drug purchasing arbitrage, or what's your policy fix?
I think you have to do that, because if you don't do that, if you don't eliminate the drug arbitrage or the drug spread as the mechanism for generating revenue, you're never going to be able to target the assistance to hospitals that truly need it. You're never going to get at the causes of consolidation, and you're not going to get at the increased Medicare spending and increased commercial premiums. So you have to get rid of that as sort of the mechanism for generating revenue. Going to a direct assistance model where assistance is determined based off of your need, maybe based off of the amount of charity care you do, or the amount of charity care you do plus the number or percentage of Medicaid beneficiaries you take care of. That will do a better job of providing, ensuring that the money is directed at those rural hospitals you mentioned, or the poor inner city hospitals, rather than these wealthier hospitals that may have, upwards of 70% commercial and insured patient mix. One of the other things we came up with in the paper, and I just think this is a staggering statistic. The state of Minnesota, I guess one of the things they did right is they mandated that they do a PBM transparency report, so you could see where the PBM revenue was going in the states. 16% of the money in the program, a program designed for nonprofit hospitals, were going to for-profit companies, many of which were Fortune 50 companies.
16%?
16%. If you extrapolated that nationally, that's over $10 billion a year going to for-profit companies for a program designed for not-for-profit healthcare entities, healthcare providers. It's insane.
That's a staggering amount. So we blew through the time and we didn't get through a lot of the things I wanted to get through, which just argues that you need to come back more. So you're coming back whether you want to or not, because we have other issues that we need to talk about. And I do think healthcare is going to be a hot topic all the way through the elections this year. There are a lot of regulations and CMMI models and everything that came out this year we need to talk about, and there'll be more to come. So Long, I want to thank you for taking the time to come on DC EKG. And wait, Long, if anybody wants to follow your writings.
Yeah, I think you go onto the Paragon Health Institute website or the USC Schaefer public policy website.
And Long, thanks very much for joining. Look forward to the next opportunity.
Yeah, I appreciate it, Joe. Thank you.
I want to thank our sponsor, Survivors for Solutions, our producer, John CZ Swartacki,